So this condition is seen in extremely high myopes. So there's choroidal atrophy, usually in the presence of a staphyloma. If you look clinically, the retina looks elevated. We don't see a hole, but the retina doesn't physically bullously detach. It just seems to be slightly off. And some of them have worsening vision. In the days before OCT, we didn't really know why. OCT shows us the real structure in these kind of eyes, the splitting of the retina. The splitting site's been proposed to be at Henle's layer and the photoreceptor layer, and the bridging cells are thought to be Muller cells, and then the French have described what they call premacular structures. There are two important subtypes. There's myopic macular schisis, in which the photoreceptor layer still remains attached. We call that foveal schisis, or that's been referred to as foveal schisis. But when the photoreceptor detaches, that's when vision drops, and then we call that a foveal detachment. This has implications, of course, on the indications for surgery. Now that there's higher resolution OCT, we see all kinds of features on the higher resolution OCT to characterize this kind of disorder. So what is the etiology of myopic macular schisis? Well, there seems to be a whole bunch of issues that causes it. So it appears to be cortical vitreous traction. We'll see that when we show the surgical videos. Sometimes the epiretinal membranes that stiffen the retina. Retinal vessel traction has been proposed to be a cause of myopic macular schisis. The vessel kind of tense up the retina. Internal limiting membrane rigidity is thought to be an important factor, and of course the extraretinal factors. The sclera is too big, or too long to stretch, and the retina doesn't seem to conform to the sclera. So it's probably a combination of these factors. A stiffened retina under vitreomacular traction or vitreoretinal traction forces doesn't allow the retina to conform to the staphyloma. The retina then separates itself into layers. And probably each different case, as we do surgery, we find that probably a different component contributes in each different case. How often does this happen? It's been estimated that in highly myopic eyes, I guess we're talking about more than 8 doctors, that it's about 8 to 34%. But of course, as you know, a lot of them are asymptomatic, so you're likely to make a wrong assessment of the common or the frequency of this disorder. The natural cause, many eyes remain stable and have good vision over years, and in this case, no intervention is necessary. A significant number progress to lose vision once you develop a foveal detachment. So this eye originally was stable with good vision, begins to lose vision as this foveal detachment develops. And if you leave it long enough, probably some of them will go on to full thickness macular holes with a retinal detachment, in which case the game is lost. Here's a nice series show the development of Stargardt schisis. This eye didn't at first, but as we followed up this patient over months, you see that schisis developing. And here's another one that seems to show, well, we're talking about natural history here. Maybe some of them do resolve spontaneously. This one sort of had an epiretinal membrane with some schisis, which got better by itself over a period of time. So not all of them will progress. Surgical management options, usually we're talking about vitrectomy with a cortical vitreous removal, ILM peel and gas tamponade, but there are all kinds of variations. There's vitrectomy and gas without ILM peel without gas, there's just a gas injection, of course there's macular buckling as proposed by some people. Generally, surgical intervention is effective in flattening macular schisis and improving vision, and eyes with foveal detachment benefit most, and surgery is indicated at this stage. Now, schisis with macular holes, of course you have to fix the macular hole as much as possible to prevent the detachment, which will lose more vision. The correct approach, vitrectomy, cortical vitreous removal, ILM peel, gas tamponade, gives consistent results. But do remember that schitic maculars do flatten even without a complete ILM peel, and every attempt is made to peel the ILM. Don't cause any damage by making an iatrogenic hole if you peel the ILM, very costly. Some interesting observations about schisis surgery. The schisis continues to flatten for some months after surgery in the absence of gas tamponade. So gas tamponade obviously isn't the thing that flattens the retina. And the fovea can flatten with good recovery even if the rest of the macula doesn't attach in the periphery. So here's a patient, for example. We operate October 2005. Vision comes back to 6.9. It's almost a year later. All right. Here's another one. Surgery done in December. It takes more than a year and some years before the vision actually gets back from 6.1 back to 6.9, 6.7.5. So there appears to be a little bit like central serous. Once you reattach retina, there is potential for recovery of vision in spite of a long period of detachment. Okay, so here's a series of our cases which we've kind of presented before. Now what's new that we've discovered over the last 1 or 2 years since we started looking at these patients? One, schisis can and often occurs away from the fovea. So it's wrong to call it foveoschisis. I'll show you an example later. Number 2, we are appreciating surgical anatomy more and more with new dyes available. And 3, surgery for eyes with no foveal detachment. How does that fare? So let's look. So here's one patient with a macular hole detachment, has a preceding schisis. His other eye, well, fovea looks okay, doesn't it? But if you cut across the upper part of the macula, it's schitic above the fovea. Below, it's not. So if you do a 3D scan, you see it's flat below, it's flat at the fovea, but it's schitic above. So there is schisis quite a lot of times in these patients, but not at the fovea. Okay. These often are asymptomatic with good vision. Often they're non-progressive. No intervention is usually required. And importantly, the term foveoschisis, I feel, is inaccurate to describe all these cases. Like delineating surgical anatomy, we had a lot of talk about dyes and staining. Let me just give my 2 cents on this. Lots of things we can use. But this is the evolution of surgery that I've had to go through. There obviously seems to be a PVD, doesn't it? There was a rice ring which we just removed. Okay? But nonetheless, we'll go through this routine of staining with triamcinolone. Lo and behold, we pick up. Now look over the fovea. We're picking up 1 layer of cortical vitreous. Well, I assume it's cortical vitreous. So 1 layer is off. Lo and behold, something else that looks like vitreous comes off too. Is it ERM or is it vitreous? Don't really know, but the second layer does come off. This is in the days when you used trypan blue. Trypan blue, at that time, we decided to do a fluid exchange and stain it. Trypan blue doesn't stain the ILM very well, but here you can see it's faintly stained blue, and the 3rd layer comes off. Alright, the next stage in evolution of dyes is in myopic macular schisis surgery. Each patient seems to be rather different. We saw just now that patient had a definite layer of cortical vitreous. Oh, that's nice to know, but thank you very much. And here again with triamcinolone, this guy has no PVD at all. And in a high myop, you think they'll be the first to develop a posterior vitreous detachment. Manesh nicely showed us a few examples, and here's one that does come off nicely with just vacuum from the cutter. Okay, now we take the opportunity to double stain it. And there we go. Now that one was trypan blue, but we chilled it in the refrigerator, so it sinks. That's one way to stain trypan blue without doing a fluid air exchange and without using glucose. Chill it. Okay. And again, there seems to be yet more layers that come off. Okay, that finally it seems like the INM layer. So again, it appeared to have like 3 layers in this particular patient. Okay, let's see the next one to play. And next in the evolution, we use after the triamcinolone. Now this one, okay, we go through that process again, but this one doesn't seem to have a layer of cortical vitreous at all. And we stain, this one is membrane blue dual, which is a mixture of brilliant blue and trypan blue in one vial. That's also made by DORC. Okay, and here something faintly comes off. It's not a very good view. But because I'm not particularly happy with that, alright, heck care toxicity, we stain it again. And now staining it twice, here you see a separate layer, again a separate layer. Shows up nicely, big blue component and from membrane blue dual, and that helps us to peel finally. Okay, now this isn't a patient in myopic macular schisis, but I just want to demonstrate the membrane blue dual. This patient has a pucker. And so we can easily peel the pucker without the staining in this particular instance. And it looks clean. But when we introduce the membrane blue dual, there you see all that wrinkle ILM which we didn't see earlier. And then again, this helps you to visualize what you left behind and be able to peel that. Okay, so stains in surgery help. There are often multiple layers of tissue to be peeled in these highly myopic eyes, but it does vary considerably between cases, so don't expect the same formula for all cases. And so these appropriate stains help us to visualize tissues for safe and complete removal. I haven't tried the blood yet, Chichun, but one day maybe I will. Okay. Now, here's a kind of a patient with what worries us a lot. There's worsening vision, but there's no foveal detachment. So what's wrong with this patient? Is that a CNV that's developed? It's just atrophy that's happening. The schisis doesn't seem to be developing. But nonetheless, this patient, we flattened it without the foveal detachment. The vision did get better. Here's another patient. All right, it looks horrible, but it technically isn't a foveal detachment, but his vision began to drop from 612 to 624. So we decided, all right, after some discussion, this is the only eye, let's go and fix it. So we do fix it, and his vision comes back to 612. So in some cases, even in the absence of a foveal detachment, there's just a plain schisis with worsening vision. So vision does seem to recover if we fix it surgically. Now, in these instances, outcomes, I think, are not as predictable. The poor worsening vision could be due to a whole bunch of things, Foster-Fuchs spot, CNV, RPE, and atrophy, and retinal atrophy, and not necessarily the schisis, but I think some patients can benefit from surgery nonetheless. So let me summarize. Myopic macular schisis is more common than we realize in high myopes. So OCT evaluation clearly is necessary because we can't diagnose it well clinically. Good vision can be retained if there's no foveal detachment or macular hole. As you've seen, schisis can develop away from the fovea, and there's no need to intervene in all cases. Progression with a foveal detachment will lead to vision deterioration, and in this time, surgical intervention can reverse pathology and improve vision. As you've seen, in some cases, even without a foveal detachment, vision does recover or improve, but it's less predictable. Finally, surgery is not always easy in high myopes, and appropriate stains and double staining techniques are helpful. And again, we come to the same question: what shall we call this disorder? It's been called myopic macular schisis, myopic macular retinal schisis. The most common term in literature is myopic foveal schisis, but I still think foveal schisis is not a good term because it doesn't always happen in the fovea. Thank you very much for listening, ladies and gentlemen.